Okay, thank you. Thank you for joining us for the SIR RFS Pain Service webinar. My name is Yanto and I'm the Pain Service Chair this year. Today, I have the pleasure of introducing Dr. David Prologo, Associate Professor at the Department of Radiology and Imaging Sciences at Emory University School of Medicine. His research has expanded the application of imaging-guided techniques to the delivery of stem cells, management of metabolic conditions such as obesity, and the topic of today's talk, the management of pain. Thank you again for joining us, and here's Dr. Prologo.
Good morning. You can hear me okay?
Yes, we can hear you.
Okay, outstanding. Well, thank you for the opportunity, and I'm excited to share this information with this group, specifically as the advanced interventional pain space is expanding rapidly during this time when many of you are training, and certainly going forward. So we'll talk about the global approach to pain in interventional radiology. I used to give these talks that would go through each procedure and all the evidence that supported it and how it evolved and so on, and it became too much. And the question that everyone wanted to know all the time was, what do we do with the patient who presents to our clinic in pain? How do we approach them, and how do we know, how do we learn the workups, and how do we know what to do with whom? And so that's sort of the reason for the structure of this talk. And then we'll talk about a few other things here at the end. The only disclosure I have now is a startup developing a cryoneurolysis device. And as I mentioned, we're going to outline some global algorithms that we can use, or a global algorithm that we can use for every patient who presents to us either on their own or through a referral mechanism, potentially benefiting from an interventional pain procedure done by an interventional radiologist. So where do we fit in? This Venn diagram, of course, is meant to illustrate the point that there are procedures, of course, that we can do that others can do as well. Other subspecialties were trained primarily in pain, and then secondarily in procedures. We were trained primarily in procedures and can learn pain. But there are, again, advanced interventional procedures that require our skill set and our technology, and those represent the area sort of independent to IR. And this is where I would encourage all of you to focus the beginning of your practice for sure. And how did all of this come about? It came about because there were simultaneous forces at work during the last, I would say, 15 years. And starting here in the top left, this is an image from a talk that I gave a long time ago, but this hasn't changed. And it's meant to illustrate that this is the flagship journal for anesthesia pain medicine. And you can see that the momentum toward imaging and image guidance is reflected here. A 9 out of 12 in a year of their journal editions included imaging, ultrasound guidance, even CT guidance, even fluoroscopy and endovascular work. So they are gravitating towards the use of image guidance because it unveils new pain generators. It increases precision and safety of their procedures. And so they're coming towards image guidance, right? And then on the other end, interventional radiologists who are already using image guidance are using technologies to manage cancer, ablative technologies, things that we're familiar with. And then we're learning about pain syndromes. And then all of these things come together. And what you have is advanced imaging guidance or image guidance performed by an interventional radiologist to target a new pain generator and new technologies that aren't really available up here in the top left. And so the marriage of all of these separate momentum generating phenomenon has landed us into an interventional pain management box here in the middle, full of brand new procedures and brand new options for historically difficult to manage clinical scenarios. So who cares, right? Is it important to anybody? And I think, again, sort of targeting this talk toward the trainee or the interventional radiologist interested in expanding his or her practice into pain, this slide is meant to illustrate who cares. And I'll start here on the left. The hospital administration cares very much, and for multiple reasons. Probably the most impactful is length of stay. There are a significant population of patients who present to the hospital in acute pain, either related to cancer or not, and their length of stay can be a financial burden it can lead to complications for the patients. And so the hospital administration cares about who can perform a new advanced interventional pain procedure that can get this patient out of the hospital, decrease their length of stay. And then we care because not only can we do those procedures, but it creates halo business. So for any new interventional radiologist or an interventional radiologist who's building practice, I promise you that the ability to manage a difficult pain scenario for a hospitalist or a referring oncologist or other will make you memorable and will solidify your relationships and will no doubt lead to halo business. In the setting of oncology, for example, standard things like radioembolization or chemoembolization and so on will follow from building relationships that manage pain. And I think it's always good to diversify our practice. No one knows what the future holds, and it's always a good idea to have more than one skill set to solidify your place in your practice or to make you more valuable as you move on in your life and in your career. Of course, there is a superimposed opioid crisis on top of all of these things that I'm mentioning. Legislators and lawmakers lawmakers and societies are generating guidelines and legislation that are pushing patients toward non-opioid alternatives for the management of pain, specifically procedural alternatives. And so this represents an opportunity for us to help human beings at a time when there is an established global opioid crisis. The image I have here under the Who Cares umbrella is that you don't know what will follow from this. And it's amazing how opening one door can lead to another door that you didn't think of. And we'll talk about some of those procedures at the end of this talk. We're all curious. It's interesting and professionally rewarding to manage pain. It's fun to manage conditions that are difficult. It's fun to help the patient, and it's fun because other people couldn't solve this problem. And so that's a motivating factor. This sports analogy is supposed to represent a seam. This guy with the ball here sort of running through this opening. It's supposed to represent a seam, an opportunity for us. There are patients out there right now. We don't have to create this market. There are patients out there right now who have access to all of the options to manage pain, including medications, including implantable devices, including surgery, who still have pain, who are still suboptimally managed. And those patients represent an opportunity for us. We're working very hard because all of these procedures are not to be done in a vacuum. And that is to say, again, assuming that this is a primarily trainee audience, many of you are going to go to private practice. Some of you will go to academics, but either way, it's not possible to ignore that we've got to have a reimbursement mechanism in place for us to perform these procedures and expand our armamentarium. And so we're working very hard on that, and it becomes a money-making opportunity as well. And then finally, I hope we're all driven to help other human beings. And if that's part of your drive and part of why you became a doctor, this can be an incredibly rewarding subsegment of your practice. So this is the slide that illustrates how my talks used to go. I would divide them into non-neoplastic pain conditions and neoplastic pain conditions. And then over the last 10 to 12 years, these talks could take up an entire day, maybe even 3 days. And so instead of running through each one of these one by one, we decided to change the approach and develop this algorithm that gives us an idea about how to manage the patient who just walks into your office with pain. And so this proposed algorithm is really the meat or the epicenter of this talk. And so we would propose and publish this approach recently in seminars that any patient who comes in, you should immediately divide them into whether or not this is a cancer-related pain and whether or not this is a spine-related pain. And that will give you 4 buckets or 4 categories of procedures, essentially, and make your approach a little bit less overwhelming. So it's either a cancer pain that's in the spine, or it's a cancer pain outside of the spine, or it's a spine-related pain that is independent of cancer, or lastly, it's a pain that's independent of cancer and outside of the spine. And once we can categorize the patient's symptoms and the patient's problem into one of these 4 boxes, we can have a more logical approach And so we can go through those boxes and sort of give an overview of the procedures without going into detail of each one of these to give everybody a first step into the management of pain through interventional radiology. The best way I think to do this is to present some real live cases and walk through them and show you exactly how we use this algorithm, at least here at Emory, on a daily basis. So a 57-year-old, all real patients here, by the way, a 57-year-old patient who comes into our office essentially with low back pain is his complaint, right? So our first question we have to figure out, is this a cancer-related pain or not? And it turns out that the patient did have a primary diagnosis of cancer, but didn't have any images in our system, but brought a disc that showed us this. Increased uptake at L5, which was exactly where he was pointing. And this wasn't referred. This is just a patient who came looking for help. So at this point, we're thinking it's probably a spine-related case, and it's probably a cancer-related case given the patient's primary diagnosis. And so what is in this box? This is the lowest hanging fruit, by the way. There's a separate talk that we give about practice building and taking advantage of the low hanging fruit first. Low hanging fruit meaning those procedures that quickly result in relief for the patient, so create a dramatic change in their course and decrease their length of stay, and also are being performed in interventional radiology almost exclusively. And so that's these procedures, and that's why I start here. Cancer-related pain that's in the spine is radiofrequency ablation and cementoplasty, these procedures that have developed over the last 10 years, primarily through Medtronic and the osteocool device, but also through what is now owned by Merit, the STAR ablation device. And there are a few other radiofrequency ablation device and cementoplasty vendors who are evolving. And the evolution of the technology followed that this pain is often acute. It's often acute because it's related to a fracture, which is your first source of pain in these patients. They've got instability from pathologic microfractures, just meaning that those fragments, once fractured, will move on each other when a patient moves, and that causes pain. And then the second source of the pain in a patient with a metastatic deposit in the vertebral body is, of course, the contact of the neoplastic cells and the soft tissues. And so with radiofrequency ablation, you can address the latter, and with cementoplasty, you can address the former. Be careful about fracture prophylaxis and local control. Certainly, these are amazing procedures that have been primarily driven by large companies, and we're thankful for the dissemination of that therapy. However, when we hear about performing these procedures to prophylax for fracture or tell the patient that this is local control of your disease, that's not what we're doing here. These are palliative procedures to manage pain. Back to the patient that we're talking about, we ended up getting a CT. Patient had a contraindication to MR, which showed us a lytic lesion that you can see here on the left, associated with microfractures, a perfect case. We approach these in a transpedicular fashion, just like we do for kyphoplasty in the osteoporotic setting, and we put a coaxial needle into the vertebral body. Through the coaxial needle, instead of a balloon, we're placing a radiofrequency ablation probe to create an ablation zone that will destroy that interface between the soft tissue and the neoplastic and address the biological component of this patient's pain. After which, we instill polymethyl methacrylate to stabilize the microfractures that have resulted from that lytic lesion, and thereby reduce this patient's pain in interventional radiology by that top right box. Next day, same patient, and had great relief from the radiofrequency ablation and cementoplasty procedure, describing to us rib pain. And so again, we know this patient has cancer, and now he's telling us he's got rib pain, but we don't know if it's related or unrelated. And so a quick digression here. This patient had great relief from the procedure that we did at L5. And I use that to quickly sort of introduce the concept of the unrelated complaint. In my career, this is I should add the disclaimer that this is sort of my subjective interpretation over the years of managing pain. The unrelated complaint is, what I mean by that is when a patient tells you about something else after you've managed their 10 out of 10 pain. If they tell you this in the recovery room or they tell you this the next day, and they say, oh my gosh, I've got rib pain, or, you know, my ear hurts, or I feel some discomfort from where the probes were, I think that's the #1 positive predictor for a good outcome. And that happens because you've got central sensitization in a patient that forms supratentorially, receiving pain signals for a long time. And when you abruptly cut off the pain signals, the so-called gates in the brain remain open and receive signals from something else. The greatest illustration I have of this was early in my career. Patient had an MFH about the elbow and was facing disarticulation, 10 out of 10 pain, bad enough to have her arm taken off for relief. We ended up taking that patient to CT for cryoablation of the MFH instead of disarticulation. It was late, actually, when it finally got finished, late in the day. Saw this patient the next day. And remember, this patient was willing to have her arm taken off. That's how bad this pain was. And the first thing that she said to me the next morning when I saw her was that she thought her contralateral leg was hurting her. And since that day, I've seen it 1,000 times. So when a patient comes to you and the first thing they tell you is a new complaint or some complaint related to the procedure, then you can feel confident that the procedure you did managed the underlying presenting pain. So back to this patient. So he did indeed have increased radiopharmaceutical activity right where he was pointing on PET. So we've got a cancer-related pain now that is outside of the spine. And so in this bottom right box, essentially what we have are really the foundation of advanced interventional pain management, and that is advanced imaging guidance, CT guidance, MR guidance for ablations. We've also got catheter techniques that we can use, and then nerve ablations, which I'll talk about in a second. But cancer-related pain outside of the spine. So we bring this patient to CT. We stand on the shoulders of giants here, and lots of work over the last 20 years describing how exactly this works. And it works not by debulking, but it works by destroying, again, the contact of the neoplastic tissues and the normal soft tissues and bones around that lesion. This is an image early in the procedure to demonstrate the visualizable ice ball, but we must get the interface, and you don't want to try and debulk these lesions. And so following cryoablation for longer periods of time, we get this entire lesion and we get this patient some relief. So changing the paradigm, I'll go back to length of stay. So going out for practice and realizing that historically a painful osseous or soft tissue metastatic deposit is managed with external beam radiation therapy. It's important to realize what your so-called competition is or what the alternative options are if you want to integrate yourself to this algorithm and help these patients. External beam radiation therapy is multiple treatments. Oftentimes they stop their chemotherapy. It's a delayed onset of pain relief. It's 12 to 14 days following the onset of radiation therapy. There are associated potential complications like pathologic fracture, infection, and so on. And then the well-known 20 to 30%. So from the radiation oncology literature, 20 to 30% of patients who undergo this therapy will not have relief. So essentially, you've got multiple therapies over a long period of time for a delayed relief, and there's a good chance, or at least a 30% chance, that you won't have relief. And so this is an issue where if we can affect length of stay by saying a percutaneous cryoablative procedure in the same setting gets the patient out of the hospital, and then they can go and have external beam radiation therapy as an outpatient. This is what we would refer to as the low-hanging fruit in the practice building arena. So we actually have access here to a large database of third-party payers and claims over the years. And so we looked at approximately 55,000 admissions, and for cancer-related pain, and we divided those into those who interacted with interventional radiology or underwent an interventional radiology procedure, and those that did not. And it was clear a significant change in the length of stay, a significant change in the length of time between the procedure and discharge decreased when the patient came to interventional radiology, and even found an increased risk of mortality for patients who underwent interventional radiology as part of that stay. And so what we are trying to do and where we want to insert ourselves has real impact. So in keeping with the same patient and the same story to sort of illustrate how we can approach these and keep with this algorithm, when we saw this patient in follow-up a month later in clinic, no more problem with his original pain, rib pain gone altogether, now telling us he has sort of a diffuse ache in his back. And so at this point we decided this was a spine-related problem, almost like the unrelated complaint, I would say. But unrelated to cancer. This was the normal wear and tear, osteoarthritis, and discogenic degenerative disease in the spine, unrelated to cancer. And so the third procedure we did was just a lumbar epidural steroid injection. And the change from the day this patient presented with a lytic lesion at L5 and then a rib-related cancer pain, and then some ache in the low back after all of this was 100 times better than when he presented, for sure. And all of that really was done in this area where interventional radiology is an expert. I guess the epidural would sort of land in here, but we had been taking care of this patient over time for a significant amount of time. So another example, not a randomly selected example, to continue to harp on length of stay, there are a population of patients with pelvic metastasis, primary pelvic masses, vaginal masses, drop metastasis in the pelvis, who end up in the hospital in acute intractable pain. And these are difficult clinical scenarios to manage because these are non-operative lesions, these are non-radiatable lesions, and in fact they're non-ablatable by us most of the time because of either involvement of bowel or adjacent bowel or other soft tissues that preclude our direct ablation. But still, this is a cancer-related lesion that is outside of the spine. We did talk about the rib lesion, which was an ablation. But I did mention that there are other techniques that we can use to manage cancer-related lesions outside of the spine other than direct ablation of the mass. And this is where these nerve ablations come in. The idea of nerve ablation, specifically cryoneurolysis, follows from the idea that using our image guidance and our skill set and our training, we can place a needle and target pain generators basically anywhere in the body with exquisite precision, because that's what we do in our so-called day job. And so when you think about the peripheral nerves, autonomic centers, and autonomic centers that are accessible to us, you can imagine that there are a huge number of procedures that we can do to help patients by decreasing the signal through their nerves. And so the way that this works is using this pelvic mass as an example, and we can talk about others. The way that this works in a non-operable, non-radiatable, non-ablatable lesion, you ask yourself, can I interrupt the nerve signal that's carrying the pain from this mass that landed this patient in the hospital with intractable pain? And if I can, does it have a motor component that is either sacrificable for the patient in order to get pain relief, or non-existent, as it is in this case? And so the pudendal nerves are nerves that run underneath the obturator internus fascia in a potential space on CT, so sort of where this dotted line is, underneath the fascia. And they are carrying pain signal with minimal motor output from the pelvic region. And so in CT guidance, we can target these nerves for cryoneurolysis. Now, the topic of cryoneurolysis is again a whole nother discussion, a whole nother presentation. But briefly, what we know we can accomplish by directing these cold centers toward nerves is the intuitive outcome, which is to attenuate the nerve signal. But it also, if done correctly and with the right device, can result in Wallerian degeneration of that nerve and then subsequent axonal regeneration, which takes a long time and translates for a patient like this into a decrease of the pain signals coming from this pelvic mass. We published a series of 10 patients done throughout Emory at our various hospitals by various operators in exactly this scenario where the patient is on the floor. The consult referral was, can you do something to help us? And we bring these patients down for bilateral pudendal cryoneurolysis and decrease the pain signal from their pelvis and decrease their length of stay. If you notice here, at least in this cohort that we reported, the change in VAS was 5.2. And so what in the pain literature, in studying pain and pain outcome, a significant VAS change is often around 2.5. And so a VAS change in a cohort of 5.2 is really quite remarkable and quite striking. Excuse me. So, few more examples, just to continue to go through the algorithm and make the point here of how we can manage these patients. 45-year-old comes, had a hernia repair, has inguinodynia, and can we help them, right? And so that's all we know at this point. We have to ferret out whether or not this patient may have a neoplastic lesion that we can address. They do not have a history of cancer, no reason to suspect cancer. And we don't think this is a spine-related lesion because it's groin pain and we've got a history and we know that nerves get entrapped during those procedures. And so we've got a non-neoplastic lesion that is outside of the spine. And when we talked about neoplastic lesions that were outside of the spine, in the bottom right box, we had direct ablation of the masses are one of our options, probably the primary option. We had some catheter techniques, and then we also talked about nerve ablations just now with the example of the pudendal nerves. Over here in the left bottom box, where we've got a non-cancer lesion that is outside of the spine, this is essentially peripheral cryoneurolysis to manage pain throughout the body, and I'll show you what I mean. So you can see here on this MR, you can see the actual mesh, right? And this is a common problem. You can see the actual mesh. You can see the fibers change deep to the mesh. What you may not realize at this point is that the ilioinguinal nerve and general femoral nerve run right in this fibrous chain, right? And so they get entrapped not only in the inflammatory tissue, but actually in the mesh itself. And so this represents an option for us to direct a cryoneurolysis device to the nerves to induce that Wallerian degeneration, to attenuate that conduction like we talked about, and get this patient some relief. But it also represents a much bigger opportunity, and it's the tip of the iceberg, but I would use this example to illustrate the huge opportunity that you have as an interventional radiologist to intervene on a patient who doesn't have other options, right? This is a patient who cannot undergo surgical revision. It's been shown that it doesn't help inguinodynia, and the complications are high. So nobody's going to want to resect this mesh. There really is no other option for a non-neoplastic lesion like this except opioid therapy. And so this exposure and dependence to opioid leads or follows from exactly cases like this. And this represents a real inflection point if interventional radiology can get in here and do a procedure to manage the patient's pain. Any procedure like this in the bottom left box, I would encourage everybody to do a diagnostic injection first to select for the patients who are going to respond to the cryoneurolysis. Essentially, what you have to do is decide where you think the entrapped nerves or damaged nerves, or just the nerves that are transmitting the signal, where they are, and if you shut them down, is it going to help this patient? So you can use your image guidance, you can use CT as we did in this case, you can also use ultrasound to infiltrate this region with bupivacaine with no sedation so that you can talk to the patient and see if you were able to take this pain away temporarily with this diagnostic injection. Those patients who respond in a binary fashion, here's the fluid, of course, deep to the mesh, and would be cutting off the signal in the offending nerves. This is a different patient, but you can see on the contralateral side how we can drop the ablation probe here. We can create ice that engulfs the offending nerves and induce that what's called a Sunderland 2 lesion and attenuate the signal and give the patient some relief. Of course, in this particular case, not to get too off topic, we always have to think about what we don't want to ablate. In this case, it's the femoral nerve. And so injection of saline here, warm saline, to protect the femoral nerve and redirection of our ablation zone away from that is important. I call this the VIP story because it illustrates a few things that I'd like to tell you. The first one is, the first one is to illustrate the point of how we, with advanced imaging guidance and our skill set, can provide options that are novel, that the patients cannot get anywhere else, and how by having those novel options at our disposal, we can solve very difficult problems. So that's the one point I want you to take away from the VIP story. The other point that I want you to take away from the VIP story is when you're building practice, you want to capitalize on cases like this, because this particular patient had easy access to all the care anywhere in the world, any subspecialist and any chair, et cetera, et cetera, et cetera. You understand that. But had these pretibial melanoma deposits that were causing him intractable pain. And despite resources and access, couldn't get any relief for these. They had already been radiated. There was no pain medicine intervention or option for this patient. And so he was being offered opioids, which is a typical scenario. And he had other things to think about, his therapy, his family, etc. But all he could concentrate on was intractable pain from these bilateral pretibial lesions. Found his way to interventional radiology, and this will be an example of something that lives right here, right? This is something that we can do specifically. And just like the pudendal case in the patient with a pelvic mass, we ask ourselves, is this, well, geez, I forgot this is the whole point of the talk, so I skipped over this. This is a cancer-related lesion that's outside of the spine, right? So either we're going to directly ablate it, which not in this case. This isn't going to be amenable to direct ablation. We're going to apply a catheter technique like an embolization, or we're going to ask ourselves what nerve is carrying the pain from this neoplastic lesion, and can we ablate it safely? In this particular case, this one was really teed up for us, right? Because this is the saphenous nerve distribution, and we know that the saphenous nerve, when accidentally damaged during a saphenous vein harvest, creates numbness, right? Creates lack of sensation in the pretibial region. So this is a nerve carrying sensation without significant motor covering the area where these pretibial metastases are. So sure, we can target this nerve under CT guidance or ultrasound guidance. We can induce the right cryoneurolysis lesion for this patient and essentially stop the signals from these painful metastases. And so this was a patient who for 18 months was living with 10 out of 10 pain and no options until he came to interventional radiology and had his pain essentially taken away. And so these are really, back to that football analogy on the early slide, this is the seam I'm talking about. This is your option. This is your chance to get in there and help somebody that no one else could. Few more cases. 51-year-old patient with pain, no history of cancer. He's got this sort of gluteal pain, gluteal cleft pain, posterior pain, but I don't know exactly. I don't know. I know there's no history of cancer, but is this a spine-related lesion or not? And so we get some imaging for this patient, and as it turns out, this was a simple synovial cyst that was pressing on the patient's exiting nerve root, as you can see, and narrowing the neuroforamen. And so this patient then falls into this box, right? Falls into the sort of bread and butter spine-related lesion that doesn't have to do with cancer. And again, that's a whole nother talk here that's illustrated here, where we go through this algorithm between axial and radicular pain and then down through all the options. But for this patient, a non-cancer related lesion in the spine is something that we could manage fairly easily and have a fairly dramatic response. It's just a specific example of one of these. But I just want you to know that this non-neoplastic spine box is also something that you can do. In this case, we just put a 22 gauge needle into the facet articulation and slowly inject lidocaine until that synovial cyst bursts and the patient's radiculopathy is ameliorated, and they're very happy with you. So globally speaking, this was the point I wanted to make this morning, that we can divide these patients into these 4 boxes. Using whether or not this is a cancer-related lesion and whether or not it has to do with the spine. So is it worth it? I used to use this slide. I still have it in here, but I talk about it a little differently now. I used to say that, you know, in order to get to the prince, in order to get to the great cases, you might have to kiss a lot of frogs, sort of meaning that you might have to deal with a lot of difficult cases in order to get the great cases. Like some of the ones that I've shown today. But over time, I believe that this is less than we actually think. And I think that we make the mistake of sort of putting the onus on the patient when we can't help them, right? Saying that they're a difficult patient or they have a secondary motivation or et cetera, when really it's sort of a failure on our part, because as the procedures evolve, some of these patients who we used to say were just difficult patients, and then we find a new target and a new way to approach their pain, and they do well. And then, as it turns out, it was us who was failing them. So I think there are much less, a much lower number of figurative frogs, as it were, in this practice than I originally thought. And I think the onus is on us to evolve and help these patients because we're the caregivers, right? We're the caregivers and we're curious. And so it's our responsibility. And so I do think it's worth it to navigate into the interventional pain space. Be careful of the other pain management doctors, et cetera. Anytime you are going to use your interventional radiology skill set to go into a new space, and we're going to talk about some new spaces as we wrap this talk up, be careful of those folks who are already in that space, right? Because they're nervous that you're going to take their cases and they won't be able to send their kids to private school anymore. So you want to be very careful about how you navigate that that space. And here's my quick advice on how to navigate that space. So right in the middle is don't be a bull in a china shop. And I think that my previous boss is on the line, so he'll understand that he was there and had to endure it while I learned this lesson right here. And that is, don't go rushing in everywhere saying that you can do everything, because that's sort of what initiates that response in others who are doing the cases already. Instead of doing that, I put this Bette Midler image here because she has a song called "The Wind Beneath My Wings," and I would recommend, instead of bursting in saying you can do everything, to take the approach that you're there to support the people who are already there. You can approach these people by saying, I'm here to help you. You're the expert. You're the trained pain. We're talking about pain. So you're the trained pain medicine doc. But there are some things that I can do to help you. So if you need help with a patient, if you've got a C1-2 lesion or something that requires advanced imaging guidance, I'll help you and I'll support you and I'll take care of that, but I won't steal the patient, right? Because we don't want the patient anyway in a long-term setting, because we're not going to prescribe pain medications. So that's a much better approach than sort of rushing in. You can never go wrong with research. Research is the great unifier. You can approach these people with, hey, why don't we do a research project together? If it's an academic center and people are worried about promotion, then we're going to be able to put our names on here and get some grants. And all of a sudden, you're on the same team looking for promotion and building your career. And that's a great unifier. And that will sort of decompress the situation. And then halo business. You're dealing with a lot of these folks already. You're dealing with oncologists, et cetera. So it's sort of a reverse halo. You can tell them, I can also help patients with pain. So just some quick advice about if you decide to do these things, how to make it a little bit smoother of a transition for you. And then objectively, is it worth it? So pudendal neuralgia is a condition that is well described. The NONS criteria are 30 years old. These are those diagnostic criteria. And so we can put this disease and we can quantify it and we can classify it, and we can manage it here. So the question is, so I've told you subjectively, is it worth it? Now objectively, you need to know, is it worth it? Because when you're doing these cases, you've got to have some objective measure of whether or not you're helping patients. Otherwise, you don't want to do it. And so what we can do here, we can do the diagnostic injection. You can see that a positive response to a diagnostic block is one of the diagnostic criteria. And you can see in CT guidance that you have filled this potential space with bupivacaine, and you can select a patient who responds to this based on that diagnostic criteria. You can take that patient to cryoneurolysis. In this particular case, pudendal neuralgia, if the nerve is damaged from a traumatic childbirth, from bike riding, from a gynecological intervention, et cetera, you can induce degeneration and then subsequent regeneration of that nerve, such that the new regenerated nerve wasn't present for the initial insult. So you've got a potential percutaneous neuroregenerative cure for these patients with damaged pudendal nerve. So it's a fascinating and exciting procedure, but is it worth it? So we reported our first 11 patients several years ago, and then started to do so many patients, hundreds of patients a year. And the question came up, is it worth it? Are we helping these patients? I'm not sure, right? And so we wanted to go back and ask these patients, were they doing better? Look at their VAS decrease and so on. I mentioned this 2.5. This is the established sort of threshold in the literature for an effective interventional pain procedure, because you can imagine that the reporting is clouded with a lot of subjectivity in pain patients. But when you think about that VAS, in addition to that being the established value in the literature, you can further subclassify these patients to ask yourself if it's worth it by performing a responder analysis. And that is essentially using a PGIC, asking patients prior to the procedure, it's a 7-point scale, compared to prior to the procedure, do you feel better, much better, the same, worse, much worse? And in that way, you can establish who responded and who didn't. And then you can flat out ask them what I call a time travel question, which is, if you could go back in time knowing what you know now, would you have this procedure done again? And if those that answer positive are your responders, at least in this cohort, we had a VAS of almost 4. A few other things, and then I'll wrap it up. We had a good talk about how to address the patient with pain, but throughout the entire thing, keep harping on this idea that we can use our interventional radiology skill set to manage new problems and solve difficult clinical scenarios, specifically with cryoneurolysis. So can we do something else? I mean, nerves do other things than carry pain signals, right? And so we think about, can we help with obesity, a huge problem in the United States? And with after some research, it becomes clear, and I use this quote to sort of reflect all of the literature over the last 20 to 30 years, and that is that interruption of the vagus nerve results in loss of appetite in humans, as well as weight loss or interruption of weight gain in all species studies. So basically, it is clear from preclinical and clinical surgical data that interruption of this vagus nerve will make you less hungry and will have you eat less. So can we then get to this vagus nerve? Can we freeze this vagus nerve, knowing where it is anatomically, and potentially affect hunger? And we did that in 20 patients, a pilot study to assess safety. But we also use that same PGIC compared to prior to the procedure. Do you feel like you are a little bit more hungry, somewhat more hungry, very much more hungry? Or on the other side, do you feel like there's no change? You're a little bit less hungry, you're a lot less hungry, and so on. And what was striking about this is that those 20 patients, over 80 follow-up points over 6 months, all reported, except for this one patient at 2 points, all reported decreased appetite. And that is something that became a big deal. We got a lot of media coverage for that, but also it was validated in the surgical literature. When they went back and looked at patients who had posterior vagotomies for other reasons, all except one experienced a loss of hunger. And so this is the real deal, being able to percutaneously manage a nerve for something other than pain. Future interventions, then, what else can we do? Lots of things. There's a lot of literature that describes prior nerve resections mechanically, prior surgical resections of nerves to manage hypertension, etc., and even hyperglycemia, but the morbidity and mortality with those surgeries and the cost is so high that it precludes the wide dissemination of those procedures. So can we instead reach these nerves percutaneously, interrupt their signal, and potentially impact other things beyond hunger, beyond obesity, including diabetes, including hypertension, and so on? And so I would encourage you, as you grow, to think about these potential applications. I feel like I'm running long, so I'm going to wrap this up here, and I'll take any questions, and I appreciate your invitation. I appreciate everyone listening, and I'll stop talking now and take any questions. Thank you so much.